Hello and namaste. Today I came with very important lecture, uh, that is anti-diabetes drug part 3. I have already uploaded two video lecture on anti-diabetes drugs. That is, first one is introduction to diabetes and about insulin, and another is a remaining part of insulin was discussed in second video lecture. Today we'll discussing about oral hypoglycemic drugs. So if you do not subscribe my YouTube channel, please subscribe my channel. Let's continue the lecture. So in anti-diabetes drugs, there are basically two types of drugs are there. One can be given parenterally and another is orally. So in parenteral drugs, we have already discussed about insulin is a very important drugs. Insulin, and that is GLP-1 analog and a myelin analog. This is given by parenterally, and other important drugs that oral hypoglycemic drugs. So those drugs given orally to treat the type 2 diabetes mellitus, that is called oral anti-diabetes drugs. Oral anti-diabetes drugs basically given orally, and mainly it is given in the type 2 diabetes mellitus. These drugs basically lower blood glucose levels and are effective orally only. That's why it is called oral anti-diabetic drugs, or also we can say oral hypoglycemic drugs, because it is these drugs given orally and going to reduce the blood glucose concentration. That's why we can say also oral hypoglycemic drugs or oral anti-diabetic drugs. In 1957, first time the talbutamol were first drugs were instituted in type 2 diabetes mellitus orally, and after that there are so many drugs available nowadays in the market which is given orally for the treatment of type 2 diabetes mellitus. If you talk about classification of oral anti-diabetic drugs, so first is those drugs which enhance insulin secretions. So those oral drugs which enhance insulin secretion, in which sulfonylurea is there. Sulfonylurea is nowadays coming in first generation and second generation. Talbutamide, chlorpropamide is a first generation drugs, while glibenclamide, glipizide is the second generation sulfonylurea. Another drugs, maglitinides, it also enhance the insulin secretion, that is rapagilinide and natigilinide. Another important drugs which is given orally and which will enhance the insulin secretion, that is inhibitors of dipeptidyl peptidase 4, that is DPP4 inhibitors. This is sitagliptin, saxagliptin, vildagliptin, liragliptin is there. And another is those drugs which overcome insulin resistance. So those oral anti-diabetic drugs which helps to overcome the insulin resistance, that is biguanides, metformin, and metformin is a very important drugs for treatment of type 2 diabetes mellitus. Another is the glitazones, or you can say thiazolidinediones, or also it is can say PPARY gamma activator, that is pioglitazone. And another classification is to retard the carbohydrate absorption. So those oral drugs which will reduce the absorption of carbohydrate, that is inhibitors of intestinal alpha glycosidase enzyme, that is acarbose, miglitol and miglibose. Another important drugs, that is some is a miscellaneous drugs. In miscellaneous drug, that is SGLT2 inhibitors, that is dapagliflozin and rimogliflozin, or the dopamine D2 agonist, that is bromocriptine. This is both are newer drugs for type 2 diabetes mellitus. So these are the classification of oral anti-diabetic drugs. Of how these oral hypoglycemic agent works basically. So those those who enhance the insulin secretion, that is sulfonylurea and maglitinides, increase insulin produced by pancreas, while biguanides decrease glucose production by the liver, while thiazolidinediones, this will increase uptake of sugar by muscles and fat cells, which will increase the uptake of the sugar in the body. Alpha glycosidase inhibitors, they will reduce the carbohydrate absorption from the gut. So this leads to better sugar levels. So this graph shows, here this chart shows how some important drugs which is commonly prescribed, that is sulfonylurea, biguanide, thiazolidine, alpha glycosidase inhibitors are working inside the body. Let's come to discuss one by one. So first drug is the sulfonylureas, or sulfonylurea basically related to sulfonamide derivative, that is very important antibiotics. So the early sulfonamide tested in 1940 produced hypoglycemia as a side effect, and taking this lead, the first clinically acceptable sulfonylurea talbutamide was synthesized. From that lead were sulfonamide prescribed for the some as antibiotics, and this leads to reduce the blood glucose concentration. From there we have synthesized talbutamide. It promotes insulin release from the pancreas. Basically it is an insulin enhancer. How this sulfonylureas acts in our body? So sulfonylurea binds with the sulfonylurea receptors 1. This will causes closure of potassium channels, which will be the ATP sensitive potassium channels, leading to depolarization, causes opening of opening of calcium channels. This leads to increase intracellular calcium influx, causes translocation of secretory granules membrane surface, leads to degranulation, and because of this degranulation causes insulin release outside the cells. So in this way sulfonylurea acts in our body. So as far as question is concerned, what are the mechanism of action of sulfonylurea, and this is very important topics or very important question mainly asked in the exam. Write down, classify anti-diabetic drugs, write mechanism of action, ADR and drug interaction of sulfonylurea. So as far as mechanism of action is very much important. So again I am repeating, sulfonylurea binds with sulfonylurea receptors, causes closure of potassium channels, leads to depolarizations, causes opening of calcium channels, leading to increased intracellular calcium and influx, causes translocation of secretory membranes, and this will leads to degranulation, and by degranulation process the insulin release outside the cell. So this is the process or procedure of mechanism of action of sulfonylurea. You can also make a note from these slides by pausing this video lecture. Of pharmacological action of sulfonylurea. As far as pharmacological action is concerned, this will lowers blood glucose level, lower elevated free fatty acid levels, normalize metabolic state of diabetes, promote weight gain, and increase number of insulin receptors. These are the pharmacological action of sulfonylurea. As far as pharmacokinetic is concerned, so rapidly absorbed from the GI tract when taken on empty stomach, extensively protein bound, this is 90% bound to the proteins, metabolized in the liver, some is excreted in the urine, avoided in patient with renal and liver dysfunctions. So when a patient is suffering from some renal or liver dysfunction, we have to take some precaution while prescribing the sulfonylurea. Adverse effect of sulfonylurea, it is very much important for as far as exam is concerned. The second generation has from fewer adverse effect. If you compare with adverse drug reaction with first generation and second generation, then second generation has from fewer side effect as compared with first generation. Hypoglycemia least with talbutamide. Hypoglycemia is there. Hypoglycemia is the major side effect of sulfonylurea, but it is least with second generation, and also in second generation, among second generation, it is again least with the talbutamide. Nausea and vomiting is common. Allergic reaction may happens, and disulfiram like reaction can be happen when consumption of alcohol. So when a patient is on diabetic patient taking sulfonylurea, they should avoid consumption of alcohol, because sulfonylurea causes disulfiram like reactions. This is a ADR. A drug interaction of sulfonylurea. So the drug that enhance the action of sulfonylurea, those drugs by taking combination with sulfonylurea which can enhance the action of sulfonylurea, which causes hypoglycemias, displace from protein binding, that is warfarin, phenylbutazone and sulfonamide. So when you taking these drugs, warfarin, phenylbutazone or sulfonamide with sulfonylureas, they will actually potentiate the action of sulfonylurea causes hypoglycemia. Those drugs, if you taking combined with the sulfonylurea, they reduce the effect. They will reduce the effect, that is diuretics or steroid increase blood glucose level. When you taking sulfonylurea, if you take sulfonylurea with these diuretics or steroid, so they will increase the blood glucose level, and action of sulfonylurea is the reduce the blood glucose level, then action may be interact each other. So these are the some drug interaction of sulfonylurea. So I have completed very important questions for as far as JAM is concerned for second professional MBBS and other courses for pharmacology. Write classification of anti-diabetic drugs and write down mechanism of action of sulfonylurea, I have discussed. Adverse drug reaction, I have discussed, and drug interaction of sulfonylurea. So drug interaction is also discussed. This is very much important question has been discussed. Come to the individual sulfonylurea. So individual sulfonylurea, there is some special points I am going to discuss. The talbutamide, this is short acting, low potency, hypoglycemia is there. Hypoglycemia least likely I am saying. These there, but among all drugs, these are least hypoglycemic action. Chloropropamide, hypoglycemia, they will increase the hypoglycemia. Disulfiram-like reaction there, cholestatic jaundice may be happen. Glibenclamide, potent but slow acting, may work when other fails. Gliclazide, antiplatelet action also, antioxidant action, may delay retinopathy, less weight gain from gliclazide. Glipizide, fast acting, hypoglycemia at weight gain, less likely, very less likely, preferred in elderly. Glimepiride, more extra pancreatic action, less hyperinsulinemia and less hypoglycemia. So these are some special points among first most preferable sulfonylureas. Among basis of these conditions, we can prescribe among the sulfonylurea drugs. Daily dose and duration of action of these drugs. So talbutamide 500 mg can be given BD or TDS, means twice a day or thrice a day. 6 to 8 hours they will act. Chloropropamide 500 mg once a daily, they will act for 36 to 48 hours. Glibenclamide 2.5 to 5 mg once or twice a daily can be given, it will act for 18 to 24 hours. Gliclazide 40 to 240 mg can be given, that is once a day or twice a day can be given, 12 to 24 hours can be action. Glipizide 5 to 15 mg can be given once a daily or twice a daily, this will act for 12 to 18 hours. And glimepiride, this is 1 to 4 mg can be given, once a day can be given, and it will act for up to 24 hours. So these are the some important point among sulfonylureas drugs. Selection of sulfonylureas. How sulfonylurea gets selected? How do you select among which one is better for the particular patients? Then, if the patient condition is fasting and postprandial hyperglycemia, if the fasting blood glucose level and postprandial blood glucose level is high in the patient, then longer acting or intermediate acting sulfonylurea can be prescribed. Only postprandial hyperglycemia, then glipizide can be prescribed. If the patient is suffering for also some renal impairment, then glipizide can be prescribed. If the patient is more than 65 years, they are elderly, you can say, then avoid glibenclamide and chloropropamide. If the patient is diabetes plus also cardiovascular disease, then you can prescribe avoid glibenclamide, cannot give any cardiovascular complications. And patient with also diabetes mellitus, hypertension, edema in the legs, then avoid chloropropamide. So in this condition, this clinical condition, this point can be considered during the prescription of sulfonylurea. Meglitinides, another important drugs which enhance the insulin secretions. So in meglitinides, this is a mechanism of action like same sulfonylureas. This is also going to enhance insulin secretions, and the exact mechanism of action is similar to the sulfonylureas. These are recently developed short and quick acting insulin releaser and enhance insulin from beta cells, more useful for post meal hyperglycemia. So those patients have postprandial hyperglycemia or post meal hyperglycemia, meglitinides is a very good drugs. The drug are rapaglinide and nataglinide. So rapaglidine and nitaglidine is a meglitine which is nowadays prescribing commonly. The design to normalize mealtime glucose exertions. It induced rapid onset, short-lasting insulin release, administered before each meal to control postprandial hyperglycemia. So it is very good drug for postprandial hyperglycemia, lower risk of hypoglycemia, mild side effect, used cautiously in patient with hepatic insufficiency. So in the if the patient is diabetic patient is suffering from also some hepatic insufficiency, then in this condition we have to take precaution during the prescription of rapaglidine or nitaglidine. The rapaglidine can be given 1.5 milligram thrice a day, or nitaglidine 60 to 120 milligram BD or TDS can be given. So this is very important drugs for postprandial hyperglycemia. Another important drugs which is help to enhance insulin secretion is DPP4 inhibitors, that is called dipeptidyl peptidase 4 inhibitors. If you talk about mechanism of action, so basically it will decrease the glucagon like peptide which is released from the gut in response to oral glucose, limits postprandial glycemia by inducing the insulin release. Usage not used in monotherapy but along with the sulfonylurea and bigonides. DPP4 inhibitors does not prescribe alone, always given with the another types of drug, either bigonides or the sulfonylureas. If you talk about mechanism of action of DPP4 inhibitors, so DPP4 is an enzyme. This DPP4 is an enzyme basically. So when incretin and GLP-1, this is the enzyme incretin hormone. When released from the intestine, when if you taking carbohydrate food or glucose, anything, any food we have, if I am going to take, any patient, anybody which is going to take food or any glucose like material inside the body, the intestine releases incretin hormone, that is called GLP-1. This incretin hormone stimulate insulin release and they will lower the blood glucose concentration. But immediately these incretin hormone degraded by DPP4 enzyme. So because of this DPP4 enzyme, this incretin hormone does not able to synthesize sufficient insulin for the reduction of blood glucose concentration. That's why these DPP4 inhibitor, they will block this DPP4 enzyme and give a sufficient time to this incretin hormone to synthesize insulin, and thereby they will going to reduce the blood glucose concentration inside the body. That's why DPP4 inhibitor is a very good drug. And apart from these insulin releaser inside the body, DPP4 inhibitor has also cardioprotective effect, antioxidant effect, and also it is very good drug for the weight reduction. So, but it never prescribed alone, always combine DPP4 inhibitor with the metformin or the sulfonylurea. So this is the exact mechanism of action of DPP4 inhibitors. Among DPP4 inhibitors, sitagliptin is there, 100 mg once a day can be given, vildagliptin 100 mg once a day can be given, saxagliptin 2.5 to 5 mg once a day can be given, linagliptin 5 mg OD can be given. Headache, allergic reaction suitable to URTI, this is very rare side effect is there, otherwise it is very good drugs when combined with the other anti-diabetic drugs.